My name is Dr. Bola Idowu, and I'm going to be moderating this session. Good morning, everyone. Thank you for joining us. This is going to be a wonderful session because we are going to be getting some of the information that has become a challenge in some of the ways that we want to handle cancer prevention, cancer treatment, and some of the clinical trials that we need to have people get into. So again, I welcome our panelists this morning, and we all have our instructions, right? Okay, so my first panelist will be Mr. Florence Gonzalez. His topic is addressing advancement of clinical trials through patient, caregiver, and community engagement. Mr. Florencia, please. Gonzalez.
I'm sorry.
Oh, okay. That's you.
Good afternoon. So my name is Florencia Gonzalez, and I work at Howard University under what is called GUTS, the Georgetown Howard University Center for Clinical and Translational Science. It is a multi-institutional consortium of medical research institutions. Our primary goal is to use research to improve human health. It includes Georgetown, Howard University, MedStar Research Institute, and the Washington, D.C. Veterans Administration. Under GUTS, we have what's called the Community Engagement Core, of which I represent, and we support the development of sustainable and mutually beneficial partnership between academic researchers and community stakeholders. So we focus on building partnerships between the community and academia to improve and advance health research. So today's, I have about, I think 8 to 10 minutes to present. So I'll try to keep it as brief as I can and stay on point. But mainly I'm going to talk about ways patients, caregivers, and communities can become more actively engaged. Oh, I'm sorry. I didn't realize it wasn't up. I apologize about that. In the ways patients, caregivers, and communities can become more actively engaged in health research. So briefly, I just want to describe the different types of health research studies that exist. First, we have treatment trials, and treatment trials are ways of trying out new drugs, new devices. And then there are prevention trials, and prevention trials can bring a real world. Prevention trials are more about preventing a disease and identifying ways that we can reduce the incidence of a disease. Then we have diagnostic studies, and diagnostic studies are those type of testing new ways of diagnosing a disease. And then we have screening studies, and with screening studies, we look at ways in which we can improve our current screening techniques, such as right now, for instance, in breast cancer research, we're currently screening through mammographies and ultrasounds, but we're looking at different ways of improving our screening techniques that may be less invasive. And then we have quality of life studies. Quality of life studies explore ways to improve comfort and the quality of life of individuals with a chronic disease. So why would you want to engage in research? One reason would be to help others. Typically, health research studies do not have necessarily a direct benefit on the person, but certainly can help the future of research and help others in the future. You can participate to access new treatment, to contribute to advancing knowledge, and also diversity is needed in health research. Currently, African Americans represent 12% of the U.S. population, but only 5% of clinical trials include African Americans. Hispanics make up 16% of the U.S. population, but only 1% of clinical trial participants. So as you can see, we certainly need more participation among Hispanics and Blacks. This is a quote by John Sebol, who is the FDA Assistant Commissioner on Minority Health. He says, clinical trial participants need more closely mirror the patients who will ultimately use the medicine. This is especially important when considering health disparities, diseases that occur more frequently or appear differently in non-white populations. But most clinical trial participants are white and male. If we do not develop a more diverse pool of research participants, health disparities may persist because we will not know if a medical product is safe and effective in the actual population that will ultimately use it. So why is your voice important? Your voice is important as a patient, as a caregiver, as a member of the community. It's important because you can help set research priorities. You can bring in the cultural and linguistic competence that investigators may not always have. You can help address barriers to recruitment, barriers that will not allow for the study to run as effectively as it could. You can help investigators understand the environmental setting in which a study is being conducted. Patients, caregivers, and other community members can help investigators be aware of these factors that may influence the success or lack thereof of a study. So there are different ways you can engage in research. And first of all, you want to look at the reason. Why would I want to be involved in research? Why would I want to shape research? Why is it important? Is there a member of my family that has gone through a chronic illness or a disease, has been affected by it? Has my family been affected by it? Has my community been affected by a condition or disease? And of course, that would be, in most cases, that's the impetus, right? There's a personal connection to why you would want to engage in research. And there are different ways to be engaged, from less intensive approaches, such as just being involved in outreach where you may be helping an investigator recruit, to more intense relationship where you are you're sharing in leadership, you're in equal partnership with an investigator, and these partnerships do exist. It's called community-based participatory research or patient-engaged research. And more investigators are going this way, and there certainly is more funding, particularly by an organization called PCORI, who is funding more and more research where patient engagement, community engagement is at the forefront of the study design or the study approach. So when we're talking about shared leadership, when we're talking about your voice being at the forefront of a study, it can be included in different phases of a study. So a study has different phases, from awareness, meaning that the investigators are getting the voice out about that study. You can be engaged in the design of the study, setting the research priorities. For instance, I'll give you a quick example. There was, I don't personally know this person, but I was at a conference the other day where a gentleman with Parkinson's disease said, okay, I'm almost done. A gentleman with Parkinson's disease said, I don't want to spill food anymore on me. And so that set off a team of individuals, community members, patients, and investigators who are developing a device so that he can steady his hand, so he can hold the spoon and then be able to eat without spilling. So that there provoked the idea of a research project. So you have more power, you have a lot of power in influencing research. So if you're interested about learning ways in which you can engage in research, please come and speak to me afterwards. There are various ways you can do so, and I'd be happy to speak to you more about that. Thank you very much.
Thank you very much for that presentation. I think it was quite educating. Because we started the session late, we are going to hold all Q&As until the end, until all the panelists have finished. So please write down your questions. We will provide the opportunity. The next person? Yeah. Okay. We're going to be listening to Dr. John Ojefo. His topic is going to be addressing the prevention measures of reducing sodium intake as it relates to cancer. Thank you.
Thank you, Dr. Abimbola, and we also want to extend my thanks to the organizers of this conference, this particular exchange, and for the opportunity to again exchange dialogue with all you, my colleagues. I'm John Ojefo from the National Cancer Institute. I'm a program director at the Center to Reduce Cancer Health Disparities. And so this morning, in another just 5 to 10 minutes, we are asked to share ideas about reducing sodium in our diets. Now, what is sodium? And I give you one typical example of what sodium might be. On June 8, 2013, a 19-year-old boy went into coma with seizure-like activities just for drinking 4 cups. This is a cup, drinking 4 of this in form of soy sauce. You might wonder, why would somebody drink 4 bottles of soy sauce? And what is the connection between that soy sauce and coma? Fortunately, the physicians at the Medical Center of Virginia, after 72 hours, were able to revive this boy. Were able to revive this boy, and he's living today. However, while my slides are waiting to be loaded, I wanted to show you that this is not an isolated condition. Why? Why that is a toxic effect, many of us here today do exactly the same thing. Why did he do it? He was daring people. It was a case of, I dare you, you cannot drink this. But what are we doing? We do that every day, all of us. How do we do it? The food we eat. Sodium, which is an essential mineral that is required for the body, but when taken into excess, is been linked to all major chronic diseases: hypertension, diabetes, osteoporosis, kidney diseases. And what are we talking about today here? Cancer. So, I have not... CASEC. Excuse me, please. CASEC, yes, it. Okay, here, crazy presentation. Okay, so that information about that board only typifies what happens in our community. One of the slides that I bring up is to show you that sodium or salt-linked diseases is one of the most serious conditions in our society. Whether here in America, in South Africa, in Europe, everywhere, sodium is linked to cancer. And what I'm trying to, I will share with you in another few minutes is the fact that, okay, how do I advance it? Okay. Okay. So, since sodium is been dubbed the silent killer, black salt should the government single out African Americans. Salt is the killer of South Africa. Salt and black people of African descent. Shocking levels of Africans. So, okay, so I've already told you what sodium is part of the body constituents, essential for our body and main component express. And so, where do we get sodium in our body? Mainly from foods. And if you can look at it, or as I was trying to, I said earlier on, if you look at the table to our left, I'm not a vendor, but I have all type of foods there. And one important thing that is so common to our ethnic group is the use of jerk beef or beef jerky. Now, beef jerky, as you'll find there, is given in about, I think, 14 ounces there. Each ounce is about 750 milligrams per ounce, and yet we take it as our snacks. We also have other things there that are even worse. Even the udus of noodle is about 1,500 in one cup, and yet that is the maximum that we are asked to take per day. Next. So this is the recommendations from various organizations, the American Heart Association, the World Health Organization. The list we are asked to give is about 1,500 milligrams per day. Particularly those of us that have high blood pressure or slightly high blood pressure, those with diabetes, all of us that are over 50 years of age or other, we are asked to take as minimal as possible. But you have a range, and the range is from about 1,500 to 2,300. Now here is the daily body intake. For ages 1 to 3, you have it as 1,500. Whereas for those of us that are 50 and above, you can take about 2,300, and that is it. Now, for equivalent, if you look at the reference guides, 1 teaspoon and a half teaspoons there for you to show of sodium is about 575 milligrams. So you can see half teaspoon what it is there, and so and 1 spoon is 2,300. So 1 teaspoon per day, the maximum that you can take is 2,300. What do? We drink as much as possible from various sources. Next. So, why should we reduce food? Why should we reduce salt intake? Because that we eat too much of it, and excess sodium in our body leads to high blood pressure, kidney diseases, inflammatory conditions, which is the basis of many of our cancer conditions, diabetes, stroke, and obesity. Next, please. Now, who should reduce sodium? Every one of us. Every one of us. And that includes African Americans, as you see from the studies that we've been doing, as well as people with diabetes, people who have high or slightly elevated blood pressure. Next, please. Now, how do we reduce it? First is to spread the news. I've been hearing about ambassadors, and we have to be action. please let us start the action with us. Let us be the role model. All of us do cook. Please, if you look to my right, you will see ingredients that you can use that do not have those salt. You can use spices. To my left, please don't use that because those are very highly loaded. No, before. No. The one before? Yeah. Okay, so next is read nutrition labels and choose lower salt options. 2, eat more fresh fruits and vegetables. 3, eat meals at home from scratch. Use herbs and spices to season. And that is why I said that guy just took four cups at once. But many of us over the day, over time, will drink one in a day. We drink over 4 bottles. Again, don't worry about diluted. If you look at 1 teaspoon, if you take 1 teaspoon a day in whatever form, you've taken too much. 1 teaspoon a day, you've taken too much. And what do I say by let us begin, let the practice begin with us. When we cook, and more importantly, when we hold parties. I went to a party last Sunday from the celebration. I was given fried fish, and when I tasted it, well, it's better said, I better keep quiet. So please, when you cook, anything you do, let us start. Let action start with us. Whether it is cleaning, if you want to cook for a cleaning, take your husband, take your spouses, take your son, take your daughter, let them know about it. Do not allow smoking. And particularly salt. When you are cooking, use low salt ingredients. So, well, this is just, in the interest of time, I will run through this and again use salt-free alternatives for cooking next. Well, this is my take-home message. I wanted to come here with the banner that I have in my home and in my office. The banner is LSP. Less salt, please, or less sodium, please. So my wife, my kids, everything, when I begin to see this, I say, LSP, oh, yeah. Every now and then, it's always like this. So please, let us start with low salt, please, in our diets. We'll be able to cut down on the health impacts that we have. The World Health Organization and every other places, many government organizations have now started with, many people are living, there are many cancer survivors who are living longer. But what? Living longer with poor quality of life. That is a major issue. So please, by reducing the salt intake in your diet, you are reducing the inflammatory conditions that predispose to all other conditions. So please, before I leave, I would like us to take a pledge. And the pledge is today. What is the pledge?
Less salt, please.
What is it again? Less salt, please. I didn't hear from the back. And it starts with us. Low salt, please. Again, low salt, please. Thank you.
Thank you so much, Dr. Oche, for this is really educational. We know it, but at times I think we end up having to be reminded. We just need that word, to be spoken into our ears once more. I'd like to call the next speaker, Dr. Bridget Opong. She's going to be speaking on international breast health and improving cancer care. Thank you.
Okay.
So
he's pulling up my slides, and I understand I guess Becca is really the person obstructing your lunch. So she'll be under a lot more pressure than I will be. But I'm a breast surgeon, and the bulk of this is just to review some of the data that you heard earlier this morning about just cancer in general, but focusing on worldwide statistics, and then of course numbers in Africa and other developing countries. And then of course things that I have done, locally to help with this. All right, great, thank you. So, use this one.
Would you
Oh yeah, it doesn't matter. Okay. Somebody yell if I'm not speaking loud enough. All right. So again, this is my quick outline. So what the problem is, and some of this you've seen earlier this morning, so I won't sort of perseverate on it. But there's a huge misconception that the main problem that Africa and developing countries have are really infectious diseases. We hear a lot about HIV, we hear a lot about malaria, and not that these are not important, but what's happening is with all of this attention being focused on infectious diseases, chronic conditions like cancer is really just sort of not being addressed while the numbers are increasing. And you see the statistic here that the incidence, the rates have been increasing by about 5% per year. And cancer, as people live longer, we see more cancer. So really, when it comes to the public health concern, you really need to shift the focus to cancer. All right, so these are some of pictures, actual women that I've seen doing international work. These are mainly from Nigeria, but, and again, sorry, this is pre-lunch. So I try to not have pictures that are too difficult to look at. But these are women who have locally advanced breast cancers. And these were sort of routine things that I saw all the time. Women are walking around with these, and even worse cases than this. So obviously, the issue also is that we really don't have the numbers, because in most African countries, there are no cancer registries. I'm from Ghana, and most of these pictures here are from work that I did in Nigeria, but it's the same situation across most of the continent. Outside of South Africa, there really is minimal data characterizing cancer. So the overall cancer burden, lung cancer accounts for most deaths worldwide, with breast being a close second. And with this is a really interesting statistic, because 70% of all cancer deaths actually, even now, are occurring in low and middle income countries. So this is a surprise, because we tend to think that cancer is another sort of more chronic, non-communicable diseases are things of more developed countries. And I hate saying the word developed, but you know what I mean, higher resource countries. All right, so moving on to a mission that I did, my very first one in Nigeria. And ASA USA is the Anambra State Association, is an organization that's actually, it's national, and there is a chapter in DC. And they started doing these missions in 2009. And I really love their efforts, because these are majority Nigerian physicians who are currently practicing in the US, and they take their skills and their resources back home every other year. All right, so this is the very first mission. I actually was not even here yet. I started Georgetown around 2011. But in 2009, they went, and a lot of this is gathering the resources, the medications, all of the surgical equipment that we would need, because when you do these missions, you have no idea the conditions that are there, All right, so, and the plan for this particular mission is usually outreach. So we go out and we educate, because as a breast surgeon, I need to have sort of I wouldn't have any cases to start, right? So the first few days of the 12-day mission is just sort of people line up, and it's really unfortunate, because I remember one day we probably had about 2,000 women in one of the villages that we went to, and it's overwhelming. It's hot. I mean, a lot of us probably have been to Africa, or at least DC even, right, when it hits that 105. Imagine that all day. And these women literally will line up from about 5 or 6 in the morning, and they stand there all day. And if I didn't get to them, they're more than happy to come back the next day. So that's the, just the amount of dedication that they had. and the resources. So pretty much, like I said, we took everything with us because we were not sure what the local facilities would have. The big things pertaining to cancer that were lacking, certainly narcotics. And this is really unfortunate because especially terminal cancers can be painful, lots of chronic pain. And this is actually a worldwide problem, but definitely a major scarcity in Africa. There's no narcotics. And like I said, I'm from Ghana. Actually, my mom called me that she knew somebody who has a bone tumor that's painful, and she said, well, what can we do? And I said, well, you need morphine, you need narcotics. Of course, they don't have it. So even if you have the money, right, if you have somebody send you funds from abroad, you just cannot purchase the medication. And I told her, well, marijuana is an alternative. So this was a preacher who I said this to, so that didn't go well. But I said, I am a physician, I promise. And realistically, that's really a natural alternative that you can use. Other things that we don't have the imaging modalities. We do have ultrasound, but in most African countries, they're geared towards obstetrics, OB cases. We don't have testing, so even if you suspect a cancer, you can diagnose a breast cancer, but the certain type, they don't have the capacity to do. So there's obviously a lot of work to do. This is a picture of the group that I went with, and the picture at the bottom is me actually doing procedures. So this was actually wonderful because the second half of the trip, I was able to do about 24 cases, which was important. Some of the barriers. So these are, just commonsensical things. The main one being poverty. In Africa, there's no, I shouldn't say there's no, most of them, if I say charity care, right? Because I showed up and I said, well, wait a minute, how come, the surgeons here don't donate some time or just do some free cases? I mean, I do that even here, and they look at you like you're nuts, right? Well, what is that? You got to pay for anesthesia, you have to pay for pathology. And in Africa, if you're having surgery, they give you a list of everything you need, including the syringes for your medication, and you need to come with it. So to me, it was a huge learning experience. But obviously, if everything is fee for service, if you don't have that money, you don't even get through the door. It's not going to happen. And the other barriers were the use of alternative medications. When people have problems and they don't have access to standard medication, they're oftentimes using the local healers. A lot of herbal medications, a lot of sort of local things, and you really don't even know what the ingredients are. But a lot of people would spend the little resources that they have to go to these local healers to see if there's any problems. And then, of course, there's superstition. A lot of women with breast problems are stigmatized. There's concerns of witchcraft. There's concerns of, people not wanting to be around them. They're ostracized from the society. So it was a very difficult thing to educate women. So I'm totally out of time, but I will just show you more pictures because I think these are much more interesting. But, again, rain or shine, people were lined up. And a lot of what I try to do is, yes, African countries, there's limited resources, but limited does not mean there's no resource, right? So you have to make do with what you have. And the big thing is you can educate. That's pretty much free, So I can tell a woman what I want you to look for. Be aware for lumps in the breast, be aware of skin changes, things that you can sort of notice that's not improving over time. And that's a lot of what we did. Just go into the marketplace with a megaphone and just blast the area. And it worked, because sometimes we did conduct some studies where you asked the women afterwards, and they were able to sort of explain what we had taught them. And that was really exciting that we were making an impact that way. And the other thing is slowly incorporating technology, Western technology, to what's already there. Or repurposing what's existing, like ultrasound. So like I said, one thing that we're doing, and I can say Ghana for sure, is OB is huge. People are having the babies, so ultrasounds do exist. And I suggest why not use that technology for breast screening, because you have a machine. You need a different probe, however, so it's not quite easy, but at least it's a cheaper way to institute some form of screening in most countries. So ultimately, this I think is my last slide. Yes. What I think we should do is to optimize what we have. So like I said, not having limited resources does not mean you have no resource, right? So I think I cannot go to Ghana, Nigeria. I was in Ethiopia last year also. I cannot go and say, well, you need to start a mammography screening program, like what we do here. That's not going to work. They're going to look at you like you're nuts. And it's unfair to sort of place that burden on the local providers, because the doctors they know the science. They're very smart. I mean, look at how many African doctors are practicing locally. They're very well trained, but they just don't have these resources. But slowly we can help them sort of use what they have, but also add things like mammography. And we were able to do that by having sometimes older machines to be repurposed and sent to Africa. And I've done that twice, and it's been really successful. All right, so I will be quiet so you can get to lunch a little sooner and take questions after.
Thank you. I think it's always very warming when you run into someone who has also been on foreign missions, as I've also had the opportunity. So I really do understand, some of the challenges that you were faced with, and really the importance of what we're talking about today, prevention, and making sure that we have the education and the information out for the people. Our last speaker this afternoon is going to be Beth Beck. She'll be talking about addressing the prevention measures and advancements of breast screening technology. Beth.
Great, thank you. Well, good afternoon, and I do realize, as Dr. Rapon pointed out, I am between you and lunch. So I will make this as brief as I can. I want to do one caveat, though, and to say that I'm going to talk about the advancement of mammography technology here in the U.S. I'm not a physician. I'm not a radiographer. I'm a public health professional, but I think I also operate a mammography facility, so I know enough about the imaging technology to be a little bit dangerous. So we'll see how we do here this morning. Is this ready to go? Okay. So a little bit about Breast Care for Washington. I'm a co-founder, president, CEO of we're a local screening mammography here. You see our mission. We basically, we're working to reduce the breast cancer mortality rate here in the Washington, D.C. area by providing access to screening, diagnostic, and access to treatment for all women, regardless of the ability to pay. And that's really key. With the Affordable Care Act in the U.S., yes, it has expanded health insurance, it has expanded Medicaid, but 30% of our population remains uninsured. So that's something that we all have to keep in mind. We're a little bit of a different a model in that we're co-located with a federally qualified healthcare center. So that's a primary care center. We're located in Ward 8, which is one of the areas in the district, you're probably familiar with it, that does have some of the highest incidence and mortality rate. And we're actually the first and only facility east of the Anacostia River that has 3D mammography, which is the state-of-the-art screening technology now. So we're the first and only at this point. There's been a lot of talk about screening mammography and mammograms and what they find and what they don't find, and it's been a huge source of, I think, debate both in the medical field and in the public field. Screening mammogram and screening mammography is the most effective way, and we know this, to detect breast cancer or breast abnormalities. We know the science is there, 10 to 25% mortality reduction from breast cancer. When I was deciding where to put Breast Care for Washington and where to start, we actually had an opportunity because we got a wonderful donation of the modality of the equipment from the manufacturer Hologic, and we needed a place to put it. So here we are, we're a new entity with no place to put this. And I was really kind of pushed by a study that came out in 2013 in the Journal of Community Health, and it found that there was actually a decrease in mammography facilities during, a 2-3 year period of time by 5%. I couldn't figure out what that was. And part of the reason for that is that when you think about this high, very expensive technology, you have to think about where it's going to go. It's going to go into a resource-rich area, right? Because you have to have staff, you have to have people know what they're doing, and you have to be able to have the facility to be able to support it. And so here we were with a resource, with a huge technology, with this very expensive technology, and we're wanting to put it into one of the most underserved areas in the District of Columbia. And the reason for this, if you don't have mammography, if you don't have the technology where the people are, they're not going to access it. So there's a reason why that, the number of mammograms during this time period declined. And this study was really looking at the rural communities, but I thought it was a nice overlay for what we were seeing in the District of Columbia. Before we started Breast Care for Washington, there was only one other screening mammography east of the Anacostia River. So now there's two. Okay, and you think about what's across the river on the other side, there's 13 or 15 at this point. So there's a huge access issue there. I'm not even going to go into the screening guidelines with mammography, but I put the slide in here because you could see that they're all over the place. Okay, so you have the U.S. Preventative Task Force, you have ACS, and then you have the American College of Radiology. I would say, particularly as an advocate that I consider myself, and our population that we serve, which is predominantly African American and Hispanic women, if you begin screening women at the age of 50 every other year, that's a huge, huge mistake. We have found, just in the 3 years since we've been open, that the majority of our cancer cases are between 40 and 50 years old. Okay, so this is a problem, and this is something that we have to address as a community. African American women of color were not considered as they were coming forward with these recommendations. So we advocate very strongly to continue to screen women at the age of 40 annually, and that's something that I think is important. Okay, so just to sort of go through, and I'm going to kind of jump through these slides. You can see that mammography has really evolved just by looking at these images. So this takes us to the 40s, 50s, 60s, 70s. Okay, so we started off very early on, no more than a chest X-ray. We really can't see the tissue. Started expanding in the 70s, where you started to get some of the tissue. They started to use compression, and then in the 90s and from 1990 really into 2000 is when a lot of the advances were made. And I'm going to talk about that because I'm going to focus on where we are today. But as you can see, in 2006, we really started to see the digital mammography, which really made a huge difference in terms of what was being detected, how it was being detected. The images were much clearer. They were actually read not on a film base, but on a computer base. So it became night and day in terms of what the radiologists were seeing. Just jump into the 1990s. So here in this country, mammography is actually one of the highest regulated from the federal level. Radiology services, there's a federal law that we all have to abide by. And so what that does is it really gives quality control on a number of different levels, not just for what the doctors are doing, but for also how we, as a mammography facility, have to communicate back to the patient and then back to the providers, because we have a certain time frame we have to do this. So it's very well regulated. You have yearly inspections. It's something, as we think about deregulation today, we hope that this doesn't get deregulated because it's a major quality care that we need to have. So in 2000, when we started to see digital mammography, the difference is that we went from this film-based, what we call analog technology, into digital technology, which made a huge, huge difference to what we were seeing. So most facilities today, probably, I would say 100% of the facilities today, are using digital mammography technology. It provides better quality images. There's a better contrast with the tissue. It was found to be much better for dense breast and for younger patients, and there's lower radiation exposure that went along with it. But just a few years ago, in 2012, 2013, digital breast tomosynthesis came out, or 3D mammography. And this today is pretty much the standard, or is becoming the standard. If the insurance companies would catch up to it and actually start reimbursing for this, it's amazing technology. And what this does is this acquires multiple images. There's no difference in how the patient gets screened. There's no difference in the timing of the screening for the patient. But it basically requires multiple low-dose mammographic projections through the breast. So we have a false positive rate gets reduced, which is important for our population because it means that we don't have to call them back so often. it's really, I can't say enough, this technology is night and day to compared to what we used to have. And an important study came out just a few years ago in JAMA, which identified that there was an increase in the detection of invasive breast cancer, which we've actually found at our facility. There's an increase in detection of all breast cancers, and then again, as I just mentioned, there's a decrease in recall for women for additional imaging. Again, that's hugely important, particularly when you have a patient population such as ours that you may or may not see again. It's very transient. So if you can get them in there, figure out what's going on at that one visit, then your success rate is going to be a little bit better. So you can see, you could sort of compare the graphic below. You can see on on your left is a 2D image versus how the 3D image works. So what happens is that the doctor can actually scroll through the image and if they're looking at an area, you can sort of scroll through that area and see if it resolves itself or if it gets a little bit larger. It's really quite amazing. This picture obviously doesn't do it justice. But it's very similar to how a CT scan is done, and that how it actually constructs the body part into the film base. Obviously, compression is still necessary. The X-ray tube, again, the patient doesn't see this, but the X-ray tube moves across, does a sweeping motion across the breast, and it captures a series of these very low-dose images as it goes across. So you get the same dose of radiation. It's really not that great. It's found when you do a single view of the breast. Now, we've been using this since our opening, and we offer this exclusively to patients regardless of the insurance status. So I want to come back here for a second and think about, this is really, really expensive technology. So part of our business model is not just based on what we get from insurance companies, but there's always going to be an arm for philanthropy, because we have to be able to pay to have this kind of technology available to the community. So just gives you a little bit of our outcomes using this technology. So you can see that we've done almost 3,000 procedures since we opened. Our average age for screening is 53. Our diagnostic exam, the average age is 49, so we're pretty high in that respect. And the shocking thing, well, not really the shocking thing to me, but the thing that I find most interesting is that over 30% of our patients are coming to us for the first time. So this is their first mammogram, and you look at their average age. So that tells you something right there. And we've identified 27 cancer cases, 4 within this last year, in this first quarter. And again, the majority of those women are between that 30 and 50 age range. And I just hit my time. So with that, I will stop. Thank you.
Thank you so much. I'd like to thank all of our panelists while we open it up for question and answer. Like someone has also reminded us, we are almost at lunchtime. So do we have questions for our panelists, please? I think you agree with me that they really did a very good job in terms of, in terms of, number one, helping us to appreciate the need to take part in clinical trials and to be able to convince that we don't shy away from it. Because at times we have the opportunity to mention it wherever we are, but most of the times we shy away from it. And we do know that, history is part of what is affecting us in this area. But at the same time, there is need in order for us to be able to get answers or to be able to find other new ways, new strategies of handling and dealing with some of these situations that, is very much in our communities. And so, what you have provided for us this afternoon is really great. And then also for our last speaker, most of the time, we're in the clinic and we're trying to understand what is being done. And there's really nobody there to explain to us. So thank you so much for helping us to understand what we go through when we are in those labs, taking the tests. And for, both Dr. Ojefo and Dr. Opong, the issue of lifestyle changes, especially with Dr. Ujefo's presentation, is very, very key. Most of the time, we just think that, it doesn't affect us. It's not me, it's about that other person. But I think with what he has shared today, it is just both me and you. So, we want to really say thank you, and we hope you will continue to support those who do international work as well, because this is also needed. Again, for coming, if there are no questions, we want to say thank you to all those who stayed with us for this session. Thank you very much, and enjoy the... Oh, you do, sure.
I just wanted to remind anyone who works in any sort of healthcare situation that there's a tremendous amount of waste, healthcare waste, and whether it's a hospital or clinic. And just because of the date, especially for me as resident devices, for example, just because the date is expired does not mean that the material is no longer good. And a lot of what I was able to do is to save some of that and take it, back home and do some of these missions. So just be mindful, and that goes for technology. I mean, we throw away like ultrasound machines just because it may not be up to standard here, but obviously when you're going to a country that doesn't have anything, it's still very useful. So just be mindful, and if anyone comes across any technology, oftentimes I've called hospitals and they're willing, if you can arrange transportation, they're willing to let you have it. And it hasn't been very difficult to get things sent to Ghana or Nigeria, or any other country, not to.
Okay, just one thing I want to add more. I spoke about salt, but there's another issue in African Americans, particularly those from our ethnic group, that I need to also address or just highlight. That is the use of palm oil. Palm oil. Those of us who take palm oil, and I think from our community, Undoli, there's a food that we enjoy so much, Undoli, which is heavily with palm oil. Palm oil is saturated, very, very saturated. About 80% of it is saturated. So please, if you can do me a favor today, please stop using palm oil. Thank you.